Hi guys, this video is about epistaxis, mainly the causes of epistaxis. So, the causes of epistaxis can be divided into local causes, general causes and idiopathic. Coming to the local causes. Local cause can be due to nose or nasopharynx. So, coming to the nose. Any trauma to the nose by fingernail, by fracture or due to violent sneeze can rupture the little plexus or the Kiesselbach plexus and can cause epistaxis. Then it can be due to infections which can be acute infections like viral rhinitis, diphtheria or acute sinusitis and chronic like atrophic rhinitis due to the crust. While we remove the crust of atrophic rhinitis, there is epistaxis. Also due to TB, syphilis and septal perforation. Then foreign bodies like rhinolith or living foreign bodies like maggots or leeches can cause epistaxis. Neoplasms, benign like hemangioma and malignant carcinoma can cause epistaxis, and atmospheric changes like high altitude Kiesselbach disease and also deviated nasal septum can cause epistaxis. So what are the local causes, nose causes of epistaxis? Trauma due to fingernail, infections, acute like viral rhinitis, diphtheria, acute sinusitis, chronic like atrophic rhinitis, tuberculosis, syphilis and septal perforation, foreign bodies like rhinolith, maggots and leeches, neoplasms like hemangioma carcinoma, atmospheric changes like high altitude Kiesselbach disease and DNS can cause epistaxis. Now, nasopharyngeal causes means something in the nasopharynx like adenoiditis, adenoid getting infected, then juvenile nasopharyngeal angiofibroma. The most common cause of epistaxis in adolescent male is JNA, then also due to malignant tumors in nasopharynx. Now, the general causes of epistaxis. So, general causes of epistaxis include cardiovascular causes like hypertension, high BP can lead to rupture of the blood vessels. Mainly they will rupture the Woodruff's plexus which is situated in the posterior part of the nasal cavity, and also due to arteriosclerosis, mitral stenosis and also pregnancy. So these are the causes of cardiovascular causes of epistaxis. Then liver disease like hepatic cirrhosis, kidney disease like chronic nephritis. This is a cause of coagulopathy and thus it will cause what? Epistaxis. Then drugs like salicylates, aspirin can cause epistaxis, anticoagulants and mediastinal tumors. Then also disorders of blood vessels, that is leukemia, aplastic anemia, hemophilia, scurvy, vitamin K deficiency and hereditary hemorrhagic telangiectasia. Then acute general infections like influenza, measles, malaria, typhoid and also vicarious menstruation, that is during the period of menstruation there can be epistaxis. So cardiovascular causes, liver, hepatic cirrhosis, chronic nephritis, drugs like salicylates and anticoagulants, mediastinal tumors, then disorders of the blood or vessels like leukemia, aplastic anemia, hemophilia, scurvy, vitamin K deficiency and hereditary hemorrhagic telangiectasia. Then acute infections like infection, measles, malaria and typhoid. Then vicarious menstruation. So next one is idiopathic causes. So this was the causes of epistaxis. A person come with epistaxis. First we have to know about some important information. First we have to ask him about the mode of onset, whether it was spontaneous or it was due to fingernail trauma. So we have to know the mode of onset, then the duration and the frequency. Then we have to know about the amount of blood loss. Also if there is any spitting or vomiting of blood also has to be asked. Then side of the bleeding, whether left or right, type of bleeding, whether anterior or posterior, and then whether there is a family history or personal history of bleeding or coagulopathy, and also about the medical conditions like hypertension, leukemia, mitral valve, that is mitral stenosis, cirrhosis or nephritis, which are the causes of epistaxis. And then drug history like analgesics and anticoagulants, which can also cause epistaxis. So we have to take a detailed history. Now we have to reassure the patient, we have to maintain his hemodynamics, and then antibiotics, check his pulse, BP, respiration and all. Now coming to the management in proper, first ABC, maintain his airway, breathing and circulation. So to maintain the circulation, get an IV access, do a wide bore needle, so get IV access. Then next is the Trotter's method. Trotter's method means make the patient sit up, lean forward with mouth open and give a firm pinching or compression on the cartilaginous part of the nose for 5 to 10 minutes. This is Trotter's method. So sit up the patient, lean him forwards, open his mouth and firm pinching or compression over the cartilaginous area for 5 to 10 minutes. Then if it is not relieved by Trotter's method, we can apply ice packs on the bridge of the nose. It is to induce reflex vasoconstriction. Then we can give mild sedation to reduce the anxiety and also analgesics to relieve the pain. Now coming to localization of bleeding, do an anterior rhinoscopy and then there we can find if it is the bleeding from little's area, and we can also do DNE, diagnostic nasal endoscopy, to find if whether it is a posterior bleeding, that is from the Woodruff's plexus. Now coming to the non-surgical hemostasis method, that is if we found out the area is little's area or we found localize the bleeding, then we can do cauterization if the bleeding point is localized. So cauterization can be chemical cauterization or electrocauterization using endoscopy. So chemical cauterization is by silver nitrate or trichloroacetic acid. So these are the agents for chemical cauterization, and electrocautery is by bipolar endoscopic electrocautery. Then if the bleeding point is not visualized, but if the bleeding is from anterior, we can do anterior nasal packing. Here we are using ribbon coats which are layered and soaked in liquid paraffin or antibiotic ointment, or we can also use Merosel or gel form. These are the modern varieties of anterior nasal packing, and this nasal packing is done in step ladder pattern from floor of the mouth to upwards. We can also do from the front of the mouth to backward in a vertical manner also, and this is put for 24 to 48 hours. Antibiotics are mandatory while giving nasal packing to prevent the toxic anterior shock syndrome. Then if it is not relieved by anterior nasal packing, means it may be posterior nasal bleeding. So we have to do posterior nasal packing. This can be by Foley's catheter or posterior gauze. So Foley's catheter, we are putting this Foley's catheter in the nasal cavity, in the nasopharynx, and the balloon is inflated and by 10 to 15 ml of saline, and we try to pull it out so that it is fixed there. And then gauze packing is also done. 3 silk ties are tied to this gauze pack and they are inserted into the nasopharynx via the mouth. And while doing nasal packing, that is posterior nasal packing, hospitalization is mandatory and SpO2 monitoring is required. Now, advanced surgical methods, if it is not relieved by nasal packs, now we can do what we can do is endoscopic cauterization, that is bipolar coagulation, and this is mainly done for sphenopalatine artery. So endoscopic, transendoscopic sphenopalatine ligation can be done, or other arterial ligations like maxillary, anterior ethmoidal and external carotid can be done. So the order is same. What is same? First sphenopalatine ligated, then anterior ethmoidal, then maxillary, then external carotid. So this is the order for cauterization. If it is not relieved by cauterization, we will do the embolization. So do an DSA, that is digital subtraction angiography or CT angiography, and then we will embolize the feeder vessel. So this is the last resort, embolization. So this was all about the management. General measures like ABC, Trotter's method, ice pack, mild sedation, and then localization by anterior rhinoscopy. If it is posterior, we have to localize it by DNE. Then we can use non-surgical hemostasis like cauterization by chemical or electrocautery method, anterior nasal packing, posterior nasal packing by gauze or Foley's catheter, then surgical devices like endoscopic cauterization and arterial ligation in the order of same, and then embolization of the feeder vessel. So this was all about management of epistaxis. Thank you.